Thank you for the opportunity to present. I have no disclosures. Access to bariatric surgery has been suboptimal and had worsened in the context of the COVID-19 pandemic that had led to mass cancellation of all elective procedures. Moreover, the COVID-19 pandemic had highlighted the importance of safely minimizing the inpatient hospital length of stay. Establishing a safe ambulatory laparoscopic surgery protocol could potentially mitigate some of these concerns, and it could help optimize hospital bed utilization, minimize case cancellation, and eventually decrease the cost of care. Safety of ambulatory laparoscopic surgery is well established for several general surgery procedures, including cholecystectomy, inguinal hernia repairs, and repair of paraesophageal hernias. And that's due to the fact that these procedures are short, reproducible, and they're associated with a low perioperative morbidity and mortality rates. As a matter of fact, laparoscopic sleeve gastrectomy is comparable to these procedures given its safety profile. Few retrospective studies have reported on the safe use of ambulatory laparoscopic surgery, ambulatory laparoscopic sleeve gastrectomy in ambulatory settings, and they reported on the safe use of these protocols. These studies have reported that the ambulatory setting was not associated with any increase in perioperative morbidity or mortality or 30 days readmissions compared to an overnight admission. However, some of these studies did not really differentiate between a true ambulatory settings versus an overnight admission with a length of stay less than 24 hours. Therefore, the aim of this study was to assess the feasibility and the safety of laparoscopic sleeve gastrectomy in ambulatory settings. We also aim to look at the impact of implementing a laparoscopic sleeve gastrectomy protocol in ambulatory settings on the length of stay, emergency department visits, and readmissions within the first 48 hours and within 90 days postoperatively. This pilot study was conducted at the McGill University Health Center, which is one of the two centers of excellence within the province of Quebec for bariatric surgery. It's a high-volume center where the grand majority of patients are discharged on post-op day 1, and where we have a well-established ERAS protocol that has been in place for over a decade with a very well-dedicated multidisciplinary bariatric surgery team. We included patients up to the age of 65, BMI up to 60, as long as they don't have any mobility restrictions, they have adequate support at home, and they're able to spend the first 48 hours within close vicinity to the hospital. We excluded those patients with ASA class more than 4 or more, those with poorly controlled comorbid conditions, including diabetes, hypertension, or poorly controlled obstructive sleep apnea. We also excluded those patients with end-stage organ failure, organ transplant, and significant cardiac or pulmonary impairment. We also excluded patients on therapeutic anticoagulation if they're dependent chronically on narcotics, if they're unable to fluently communicate in English or French, or if they're planned for revisional bariatric surgery, for example, adjustable gastric band removal along with a sleeve gastrectomy. In summary, these patients were seen at their visit for the preoperative assessment, and they're screened for eligibility. If the patients were found to fit into the inclusion criteria, they were offered enrollment and they were consented. The patients received standard preoperative workup and education and material, and they were extensively counseled about the expected postoperative course. These patients were scheduled as the first or second case of the day. They underwent a standard laparoscopic sleeve gastrectomy procedure using standard anesthesia protocol that focuses on minimizing opioids and minimizing postoperative nausea and vomiting. The patients received at least 1 liter of crystalloids, and at the end of the procedure, the patients received a laparoscopic assisted tap lock. In the recovery unit, the patients received at least 1 liter of crystalloids as well, and they had a hemoglobin check at 4 hours postoperatively to ensure stability of their hemoglobin. Subsequently, they were assessed by the surgical team at 4 to 6 hours postoperatively to make sure that they're fit for discharge, and if they're stable, they were discharged home. The patients had 2 phone follow-ups. The first phone follow-up was in the evening of surgery, and the second phone follow-up was on postoperative day 1 in the morning to screen for any alarming symptoms. And then if there are any alarming symptoms, the patients were asked to present to the emergency department. Other than that, the patient had the standard postoperative follow-up with the multidisciplinary team. A total of 55 patients were planned for ambulatory laparoscopic sleeve gastrectomy between February 2021 to February 2022. The median age was 43, and the median BMI was 44. The grand majority of these patients were ASA class 2, and the median length of stay was 6 hours. We had no conversions and no intraoperative complications. All of the patients were discharged home as planned, with the exception of 2 patients. The first patient needed to stay overnight due to uncontrolled pain and nausea, and the second patient had history of asthma. She required oxygen and bronchodilators postoperatively, so it was felt that it's safer to keep the patient overnight. We had 0 mortalities, and none of the patients presented to the emergency department within 48 hours. However, we had 2 patients who presented to the emergency department within 90 days. The first patient presented on post-op day 13 with vague abdominal pain and was discharged home after complete negative workup. And the second patient presented on post-op day 35 due to history of dehydration and acute kidney injury, and she required a brief admission. While we did not really formally collect any data on patient-reported outcomes or quality of life, the overwhelming majority of the patients reported that they were happy and quite satisfied with the experience. They were happy that they were able to spend the first night at home, recover with their families, especially in the context of COVID-19 pandemic, where the patients were not really allowed to have any visitors around. This study has some limitations beside the small sample size. It's a single center and non-randomized study. And as I mentioned earlier, we did not really formally document data on quality of life and patient-reported outcomes. However, the study was done in a true ambulatory settings, meaning that the patients were not really discharged to a hotel that is attached to the hospital. The patients were not asked to come next day for intravenous hydration or any extra treatment other than the standard treatment. The study also has a very well-defined inclusion and exclusion criteria, which could help with reproducibility of the protocol in other sites. In conclusion, ambulatory laparoscopic sleeve gastrectomy is feasible and appears to be safe in carefully selected patients. And really, multidisciplinary patient education and management of expectations are key here for the success of this protocol. We do need larger studies with standardized protocols to help guide the safe use of ambulatory bariatric surgery. And as a future direction, we're planning to start collecting data on patient-reported outcomes and quality of life for the subsequent cohort of patients. And we're extending the protocol to include laparoscopic gastric bypass procedure in ambulatory settings as well. Thank you. I'll be happy to take questions.